Hi, I'm Vicky McDonald. I'm a consultant haematologist at Guy's and St Thomas's hospitals in London, and I'm going to present some of the abstracts that give us some insights into how we can optimise care for patients with chronic ITP using data from EHA and ISTH 2024. I'll be presenting some abstracts, and then I'm going to be joined by Professor James Bussell and Professor Walid Ghanima to then have a discussion around those topics of how we might implement them and point out the key takeaway messages. The first section that we're going to talk about is how does ITP impact the patient and their health-related quality of life? And certainly this is something that for those of us that see ITP in the outpatient clinic setting, it comes up quite a lot as a topic to say, well, how can they feel better? How can we get them functioning back at work and everything else? So one of the abstracts that was presented was around fatigue in adult patients with primary ITP. This was a real world data, and the clinical trials specifically for fatigue, I think, are very difficult to perform. But this real world data came from the Vienna ITP Biobank, and they tried to compare fatigue levels between adult patients with primary ITP, of which there were 73, the most of whom were chronic or persistent, and an established kind of normalized group from a German normal sample control. And they use the FACIT-F scale for fatigue, and there's a variety of fatigue scores, quality of life scores, some of which are more ITP specific and some of which aren't. But they chose to use the FACIT-F scale, which has 13 items on a 5-point scale, looking at fatigue over the last week predominantly, so relatively short term, with higher scores representing less fatigue. So for patients with fatigue in primary ITP, the fatigue outcome mean FACIT scores in this study for all patients overall was 39, and for chronic persistent ITP patients was 39.6, for newly diagnosed patients was 37.9, for the norm group was 43.5. And the p-values shown are relative to the norm group, but we can see that there is a statistically significant reduction in the FACIT-F scores for all of our patient groups in ITP, whether it be chronic, persistent, or newly diagnosed compared to norm. The team went on to see if there was any specific correlation between fatigue and selected clinical ITP parameters. And they looked at platelet count, vitamin D levels, ferritin levels. By a univariate analysis, there was a suggestion that platelet counts and ferritin levels were associated. But when they brought in the multivariate regression analysis, ferritin was the only significant predictor of fatigue, which we would anticipate, given that ferritin is a cause of fatigue anyway, certainly would highlight and signpost that in patients with primary ITP, we ought to be looking for more broad causes and other remediable causes of fatigue before blaming it on the ITP alone. The next abstract that we wanted to highlight around quality of life and impact for patients with ITP was an abstract looking at venous thrombosis. This was data coming from the Carmen French registry, which is a large cohort of patients. We do recognise that there is an increased risk of ITP, of thrombosis in ITP, and it's thought in part to be disease-driven, but we still don't really understand how we should optimally manage that, how it should impact our choices of therapy, and how those thromboses necessarily behave, and do they behave any differently than patients without ITP. So the Carmen French registry group includes patients over the age of 18 with newly diagnosed ITP, and they included from this block patients from June 2013 to May 2022 diagnosis. And they looked at the real-world incidence of venous thrombosis and focused on a subgroup of patients treated with a thrombopoietin receptor agonist. As we know, there has been plenty of literature and discussion around whether those agents in particular might slightly increase the risk of thrombosis on the background of the increased risk in ITP, but it still remains unclear with quite variable data sets across the board. And it's certainly a degree of anxiety, I think, when you're discussing starting some of these agents in clinic as to what the background thrombosis rate is. So of 1,304 patients included in the study, 53 experienced a venous thrombosis with a median follow-up of 20 months. And the median age in the VTE group was slightly higher than the non-VTE group, but not significantly so. There was a much higher rate of prior thrombosis in the patients who had a thrombosis in the registry at about 24.5%, and a slightly higher percentage had secondary ITP. There was a trend to a lower platelet count at diagnosis in the thrombosis group compared to the non-thrombosis group, so the platelet 8 versus 18. And then the treatments during follow-up, 94% had corticosteroids in the VTE group, 49% IVIG, and 62% TPO-RA. And there was a difference in the TPO-RA treatment rate compared to the non-VTE group, which was 28%. Of note in this study, most VTE events occurred within the first 3 months of diagnosis of the ITP, and the cumulative incident rates of VTE at 1 year were 2.2% and at 5 years was 3.7%. So the summary from this data was that a higher proportion of patients with VTE had a history of thrombosis, secondary ITP and more severe disease, and were treated with TPO-RAs versus patients who did not experience VTE. It'll be interesting to pick up this discussion in the discussion section, particularly around the TPO-RAs. The description of the VTE events and the management practices. So 20 patients had atypical VTE events. Of those, 5 were cerebral events and 4 were cerebral events in platelet count over 250. The bleeding and thrombotic events in patients experiencing thrombosis after receiving anticoagulation for either less than 3 or greater than 6 months, of which there were 31 patients. So as 1 patient had a recurrent thrombosis less than 3 months, and there was no hemorrhage on anticoagulation. Patients treated with the TPO-RAs had an increased risk of VTE at an atypical site, and the TPO-RAs and anticoagulation was an effective and tolerable management strategy. And again, we look forward to discussing that in the discussion section. So one of the other key areas for women with ITP is heavy menstrual bleeding. And we all recognise that in inherited bleeding disorders, there is certainly an increased risk of heavy menstrual bleeding with quite significant consequences on quality of life. But in ITP, this is much less studied. And this abstract looked at the frequency of heavy menstrual bleeding in at-risk adolescents with ITP, as well as inherited platelet disorders. So it was a retrospective chart review at a paediatric centre to look at the frequency and severity of bleeding in a cohort of female patients with ITP and inherited platelet disorders over the age of 10. Heavy menstrual bleeding was defined as bleeding requiring a change of protection more than every 2 hours, bleeding throughout protection, sensation of flooding, bleeding lasting more than 5 days, and bleeding affecting quality of life. And iron deficiency had been defined in this study as a ferritin of less than 10 nanograms per deciliter. So overall, there were 420 patients, 298 with ITP and 122 with inherited platelet disorders, and that reflects the relative frequency of these diseases. The frequency and severity of heavy menstrual bleeding, we can see that the incidence of heavy menstrual bleeding in at-risk patients with ITP was 43.5%, no heavy menstrual bleeding 38.1%, and 16% were premenarchal. In patients, the hospital management of heavy menstrual bleeding in patients with ITP, 40% did not need a hospital admission, 38% needed some kind of inpatient care, and 16% needed an emergency department visit. There's also a small group of patients who are recorded as requiring intensive care unit admission. So it shows that actually approximately 50%, just over, do need some kind of hospital-based, inpatient-based care, which is quite a big impact, I think, with children with ITP. And treatment of heavy menstrual bleeding in patients with ITP was ITP-directed long-term treatment for 24 patients, plus hormonal therapy for 16 patients. Again, as we've seen in the fatigue data abstract, a significant proportion of these patients were iron deficient, so crucial to look for this. And and 28% of patients with ITP or an inherited platelet disorder were then treated for iron deficiency anemia. So the summary of this data is that heavy menstrual bleeding is common in female patients with ITP and results in high rates of hospitalization with significant impact then on that family and child. And we should be looking out for this and actively managing it where we can, and trying, I think, when we can discuss this in the group again, the implications for how we address this in the outpatient clinic as the children transition into adulthood. And iron deficiency is common in female patients with ITP and heavy menstrual bleeding. And I think I'd certainly look forward to more data on this as we can understand it. So I'm going to bring the panel into discussion here now, having looked at some of the key papers on how ITP impacts the patient and their quality of life. And I'd like to bring in my co-faculty, Professor Bissell and Professor Ghanima. Welcome. So I think there's a few discussion points that have been raised by this. And I think if we could start with Professor Ghanima and the impact of ITP generally on patients and whether this real world data on fatigue compares with your experiences in clinical practice.
Yeah, hi, Vicky. Yes, absolutely. I mean, we know now very well that ITP impacts on the quality of life of patients. Fatigue is a real problem among ITP patients. So this is actually in line with what we observe or what I observe in a clinical practice. What this abstract add is the association or the of ferritin with the level of fatigue. That's something that, to my knowledge, has not been shown before.
And Jim, what do you think?
I'd love to comment on the ferritin, because on the one hand, if ferritin's low, as Vicky said, that would go with the iron deficiency. But on the other hand, there's, as I'm sure both of you know and many of our audience would know, there's a thought that inflammation contributes to fatigue in ITP, and ferritin would be high in those patients. So it might be kind of an interesting marker to look at. Walid, what do you think about thrombosis, and especially about the atypical sites?
Yeah, I mean, I was kind of surprised by the atypical sites because in previous studies and in my experience, most of the thrombosis we see, or the venous thrombosis, they are the kind of typical thrombosis of deep vein thrombosis and pulmonary embolism. We see sometimes the cerebral vein thrombosis, and this is a point that I want to bring up here, because headache is a common side effect of thrombolytin agonist, and many patients come complaining of headache, and at the same time it's a symptom of cerebral vein thrombosis. So I want to draw the attention of the audience to this point. When a patient comes with headache, they have at least to think of this complication. I mean, the possibility of thrombosis. The other issue, I mean, here, it's just a presentation of data without any statistical test, but we can see here that looking at the various factors and how these are prevalent in the group of thrombosis versus non-thrombosis, we see that the use of thrombolytin agonist was associated with high, or more prevalent in the prognosis group, and then the prior thrombosis is now being shown in many studies. It's a risk factor, so that's something we have to think when we use TPO, and also secondary ITPs.
I think Dr. Ghanima is too modest to mention that he and his wife, Dr. Garabet, have published by far the best studies on how TPO influences coagulation activation and platelet activation and might contribute to thrombosis. And as Dr. McDonald said, this is heavily debated as to how much TPOs contribute. one of the things I was struck by was they said most of the thromboses were within 3 months of starting treatment, of diagnosis. So I wonder if maybe even if those patients got TPOs later, if they were not even on TPOs when they had the thrombosis. And just to finish on the heavy menstrual bleeding for 1 minute, estrogen is known to worsen autoimmune disease, but progesterone actually at one point was proposed as a treatment for ITP. So I've had in my practice the idea that if you have heavy menstrual bleeding in a woman with ITP, to use a progestational agent instead of an estrogen-based one. And as Vicky said, iron replacement, assessment and replacement is key.
Jim, can I comment on this also, that the heavy menstrual bleeding? I think there's a huge geographical differences. I'm not sure where this study was done, but the prevalence of anemia and heavy menstrual bleeding and certain countries, at least I know in India, is very high compared to Europe. And are we good in the Western part of the world at detecting anemia and heavy menstrual? I don't think so.
Well, I especially don't think so. And I'm a little confused. This was apparently a US study, but it's from a pediatric center. So if this was predominantly adolescents, I think we're terrible at it. If this was adult females, I think it would have been better as far as that.
In this section, we're going to look at what the latest data is that might help us inform the use of current treatments for chronic ITP. First study we're going to look at is the Stop-A-Go study, which is looking at the prolonged response after thrombopoietin receptor agonist discontinuation in primary ITP. This was a prospective multi-center study, and it recruited adult patients with persistent or chronic primary ITP. If they had a stable complete remission, which was defined as platelets over 100 for over 2 months after treatment with eltrombopag or amplostim for more than 3 months, they could be included. And the TPO-RAs were gradually tapered and then stopped over 10 weeks according to their standardized practice. The main outcomes that were reported was a sustained response off treatment, which is defined as a platelet count of over 30 and no bleeding without ITP-specific medications, and a sustained complete response off treatment, which is a platelet count of over 100 and no bleeding without ITP-specific medications. Overall, 48 patients were enrolled between September 2017 and February 2020. The baseline characteristics of the 48 patients, 63% had chronic ITP at thrombopoietin receptor initiation. The median duration of ITP at stopping the TPO-RA was 6 years. 47% had more than 2 lines of treatment, and eltrombopag was the most common TPO-RA. So I think to highlight in this data, these patients had had ITP for quite a long time, and a significant number had had more than 2 lines of treatment. The median duration of follow-up was 5 years, and the clinical response after stopping the thrombopoietin receptor agonist, the sustained response of treatment was 52% at 1 year, and 47.9% at over 4 years, and the sustained complete response of treatment was 29% at 1 year and nearly 40% at just over 4 years. There were 2 patients who relapsed more than a year after TPO-RA discontinuation, and chronic ITP at TPO-RA initiation was a risk factor for relapsing with an odds ratio of 5.4. So the summary from this data is that over 50%, or just about 50% of patients maintained a sustained response of treatment for more than 4 years after stopping their TPO-RA. There were only 2 cases of relapse reported during long-term follow-up. It's confirming most cases of relapse occurred in the first few weeks after discontinuing. Moving on to some real-world data around fostamatinib, the spleen tyrosine kinase inhibitor in adult patients with chronic ITP. And this was a retrospective observational study from Italy of patients with refractory symptomatic chronic ITP treated with fostamatinib. The patients needed to have received over 1 dose of fostamatinib outside of clinical trials, and their primary endpoint was the proportion of patients receiving fostamatinib for more than 6 months. Other endpoints related to platelet counts. And they had 91 patients enrolled, which is a large cohort for real-world data of this particular agent. So the baseline characteristics, 57% had previously received more than one thrombopoietin receptor agonist, 23% had had a splenectomy, 83% had had more than 3 lines of prior treatment, and the median time from ITP diagnosis to fostamatinib therapy was 7 years. So again, reflecting a very refractory group of patients with fostamatinib being brought in where their other lines of agents have failed. 66% had an overall response within 3 months, 33% had a complete response, 40% were still receiving treatment at 6 months, and 78% needed the higher fostamatinib dose. 38 patients had side effects, and 59 side effects reported overall, with the most common, as we might expect, diarrhea and hypertension, transaminitis. And the treatment discontinuation due to side effects was prominently because of neutropenia, transaminitis, hypertension, and diarrhea. And there was only 1 DVT 5 months after stopping fostamatinib. So the summary is that 40% of patients with refractory chronic ITP received fostamatinib for 6 months, suggesting fostamatinib is an effective therapeutic option in real-world practice with an acceptable safety profile, in particular the thrombosis rates. And then moving on to what is probably considered a more old-fashioned treatment for ITP, looking at the outcome of splenectomy in refractory ITP using the data from the UK ITP registry. This is real-world data based from the United Kingdom, and they took all of the registry patients and looked at the 5,322 who'd been enrolled at the 410 who had undergone a splenectomy. 251 patients had had their splenectomy after the year 2000, when the procedure was increasingly used for refractory patients rather than earlier in the therapeutic lines. And refractory in this study were defined as having 3 or more lines of therapy. The patients were divided into 2 cohorts, 2 or fewer lines of therapy before splenectomy, and 3 or more lines of therapy after splenectomy, with 102 patients having 2 or fewer lines of treatment and 149 patients having 3 or more lines of treatment. And the surrogate measure of splenectomy failure was the median time to first treatment after splenectomy. The outcomes associated with splenectomy in the patients from the registry data, the median time to first treatment after the splenectomy was 20.83 months in those who'd had 2 or fewer prior lines of treatment, and 3 months in those who'd had 3 or more lines of treatment. The treatments prior to splenectomy, the 2 or fewer lines, 2% received rituximab, 2% mycophenolate, and no TPO-RAs. Those who had 3 or more, 39.6% rituximab, 17.5% mycophenolate, and combined 30% of the TPO-RAs. In addition, a point to note is that the time to splenectomy failure was significantly shorter in patients over the age of 65 versus patients under the age of 65, which adds to the existing literature on age and splenectomy response. So the summary from this data is that the probability of splenectomy inducing sustained remission in refractory patients with ITP is considerably lower versus non-refractory patients, with, as I said, refractory being defined as 3 or more treatment lines. And I will bring in James and Waleed again to hear their thoughts on the data that's been presented, because I think there's lots of discussion points around these abstracts.
Yeah, I would like to comment. The first study is Topago, and it's really interesting and important study. Well, we have now 4 studies, prospective studies on tapering, and all of them are showing more or less the same thing, that we can taper and discontinue thrombopoietic agent, and around 30% of the patient would remain in remission, so-called sustained response of treatment after discontinuation. Well, this study is slightly different because they started tapering if the patient had a platelet count, sustained platelet count of longer than 2 months, and they've been on treatment for more than 3 months. And that's why they reached a higher a proportion of sustained response, up to 50%, compared to the other studies, which shows around 20 to 30. This is one point. The other point is that this is the only study, or the first study, showing so long follow-up. That's very reassuring, that even at a median follow-up of 4 years, we still don't see, I mean, we most of the patient remain in response without need of treatment. The issue here, or the important question that this study raises, should we push the platelet count to over 100, which is not the practice, because we use the lowest dose that keep the platelet count in a safe level, like 50 to 70, 80. But here it's showing that if we push it to over 100, probably we have a higher chance of getting a sustained response of treatment.
Right, Waleed, I was struck as you were by the 100,000 too. So I don't know if pushing people with higher doses to 100 will be the same as having the, let's call them, very good responders selected for this. But I do think it's encouraging that, as you pointed out, so many could discontinue.
And I think we need protocols also to protocolize this in every center, country, or region to be sure that we follow this practice.
It would be very interesting in that regard to randomize, where you take patients and every patient you push over 100 versus you allow them to be 50 and then see what happens. That'd be really cool.
Great idea. So what do you think, Jim, about the real world data from Italy about fostamatinib?
I've thought about it a couple of times and changed my opinion looking at it more. Initially, I thought, well, 66% response, given that I'm assuming that's one platelet count over 50,000 in 3 months, not so great. But then you're thinking, well, these, as Vicky highlighted, were very refractory patients, and 40% of them were able to use this treatment despite having had multiple lines of treatment fail previously, including often or reasonable percent TPO agents. So I thought it was pretty good. The side effects recapitulated perfectly what we had seen in the clinical trials. So I thought it was a reasonably nice study, as Vicky pointed out, a lot of patients in it. What did you think, Waleed?
Yes, I agree. I think this is a very heavily pretreated population. We don't expect higher response rates, and the 40% that remained at 40 at 6 months, I think it's a very good rate. And also the side effects. I mean, the diarrhea, hypertension. In practice, we are not seeing that high rates as in the randomized trials at around 30%. Anyway, my message here also that we need to follow up on the blood pressure after starting, and the liver enzymes. Yeah, so that not to miss and hypertensive crisis.
I'm going to disagree, just in the sense that we did see that frequent side effects, but certainly could be population dependent. What did you think of the long-term response to splenectomy, that study?
I love this study because we don't have such data. We actually, this is what's happening now. We have pushed and delayed and deferred splenectomy, and into a stage where we consider it when the patient is really refractory to multiple lines, and when the patient arrived this stage, there are two questions. Does the patient have ITP actually? Are we treating an ITP patient? And the second one, what is the response rate when we are reaching at this stage? And there has been some literature review saying, well, it's the same as used to be, like 60%. But this study shows something totally different. It shows that it's much shorter time to treatment failure in patients who's been exposed to more or refractory to 3 or more lines versus earlier.
Yeah, I think just as you said, splenectomy's been generally pushed back. I'm actually impressed that the British registry had as many as they did, or the UK registry, excuse me. And it was interesting because in the earlier data, it looked like if you didn't respond to steroids, there were a number of studies that said in early patients, you wouldn't respond to splenectomy. And similarly, there was data like that for IVIG and even one study for anti-D. So the question was, if you didn't respond to anything, is that somebody you should do a splenectomy in, or is that somebody who it wouldn't work and you'd just be digging yourself in deeper? And this study suggests for longer-term patients, you're digging yourself in deeper. And it would be great if we could predict better. And I had been a big believer in the sequestration studies with autologous platelets, especially the ones that were done at St. Bart's, not St. Bart's, but we have to get more data and see if that's a useful marker.
We're going to talk about the data for emerging chronic ITP treatments and what they tell us. And it is great to see that there are some newer agents coming through for ITP, because there's definitely some unmet need for certain patient groups. The first abstract we'd like to talk about is the efficacy and safety of a new spleen tyrosine kinase inhibitor, sovleplenib, in adult patients with primary ITP, and this trial was performed in China. This was a randomized double-blind placebo-controlled phase 3 study. And adults with primary ITP more than 12 months duration who'd received at least one previous treatment for ITP were included. One concomitant ITP therapy was also allowed during the trial. And patients were randomized 2-to-1 to receive a drug versus placebo with treatment for 24 weeks and a 4-week follow-up. There was an option to roll over to open label, so hopefully longer term we will get some longer term data on this. And the primary endpoint was a durable response rate. Key secondary endpoints were an overall response rate, time to treatment response, reduction in rescue therapy, and reduction in concomitant anti-ITP agents at baseline. They also looked at bleeding scores and quality of life. The baseline demographics and characteristics showed for the overall 188 patients, the median age wasn't significantly different between active agent and placebo. The median time since first reduction in platelet count to randomization was similar, as approximately 7.6 years. The baseline platelet count was less than 15 and 60% of patients across both groups, and a similar percentage, 4 and 5%, had received a splenectomy. And approximately a third of patients had concomitant anti-ITP treatment at baseline. There was some imbalance on the baseline characteristics on previous TPO-RA therapy, in that a greater proportion of patients in the sovleplenib arm had a prior TPO-RA than the placebo arm. And there was a slightly higher WHO bleed score in the sovleplenib arm as well. So looking at the primary endpoint, the durable response rate was 48% in active agent and 0% in placebo. And the platelet-related secondary endpoints, a single platelet count of over 50 was seen in 71% of patients who received sovleplenib, and 16% of patients who received placebo, and similarly positive response on 2 consecutive platelet counts of over 30 and a platelet count of over 30 and an increase from over 20 from baseline. So all the platelet measures and the durable response measures certainly showed that sovleplenib significantly increased response in the intention to treat population over placebo. Looking at the drug exposure and safety analyses, so in addition to is this effective, is it safe, the median duration of exposure weeks for sovleplenib was 24.1 and placebo 12.1. 99% of patients had at least one adverse event, and 25, because that was grade 3 to 4. 85% had a treatment-related adverse event in the placebo arm, and 24% of those was grade 3 or 4. We can see the most common adverse events were upper respiratory tract infection, COVID-19 because of the time the trial was performed, and increase in LDH. However, I think the more important ones that we would be interested in this abstract are comparing it to the other SYK inhibitor we have, which we know reports from our earlier talk on GI toxicity. So actually this SYK inhibitor had low GI toxicity rates. So we're not seeing an increased risk of GI toxicity in this patients treated with this agent. There was a slightly higher hypertension rate at 12.7 versus 6.5. So comparing our existing agent, we can see that the GI side effect profile certainly seems quite favourable. And I'm sure we will come on to this in the discussion. Importantly, there were no thromboembolic events occurring. And I think in the context of what we discussed in the first session about quality of life for patients, this is important. In the subgroup analysis of the agent, the authors reported higher response rates in patients with chronic ITP who had had fewer lines of prior therapy, and also whether the patients were on a TPO-RA or not, or had previously had a TPO-RA or not, didn't seem to impact response, but there will obviously be further data on this over time. So moving on to another agent in ITP, which is in a slightly more advanced stage of development, I think, and approval process. This is the oral Bruton tyrosine kinase inhibitor, rilzabrutinib. So this is a pooled analysis of efficacy and safety of this agent in patients with previously treated ITP from a phase 2 study. And this is taking data from the part A, which was dose finding, and part B, which is the selected single dose of the LUNA-2 study of rilzabrutinib. Adult patients between 18 and 80 years with platelet counts of less than 30 were included, and the patients had to have had a response to one prior line of ITP therapy. Oral rilzabrutinib at 400 milligrams twice a day for 24 weeks was used, and the clinical assessment outcome measures was overall platelet response, which was 2 consecutive platelet counts over 50 and an increase of over 20 from baseline without needing rescue medication, with a durable platelet response of a platelet count over 50 on 8 to 12 weeks of the 24-week treatment period without rescue medication. The baseline characteristics, the median age was 52 years, median duration of ITP was 7 years. So again, a chronically treated a group of patients with long-standing chronic ITP. Median platelet count was 14. And the durable response rate was 28% with an overall response rate of 41%. When patients were on rilzabrutinib monotherapy, the response rate was 42%, and in combined therapy was very similar. And 35% of patients had a complete response. So in the context of patients with a low baseline platelet count and very chronic ITP, this shows rapid and durable response rates and very promising therapeutic area. Looking at the overall response by baseline variables, there was no difference between chronic and persistent ITP, no statistical difference between chronic and persistent ITP. There was a slight propensity to increase response by shorter duration of ITP. There was a better response rate in patients who had a lower number of unique therapies, and a lower number of lines of therapy. And so patients with fewer prior and earlier lines of therapy had higher platelet responses versus those who'd had more later lines in therapy. And this is a running theme through all the talks we've talked about today. The safety data is very positive. There were only 17% of grade 3 adverse events or more, and 8% leading to treatment discontinuation. And most of the adverse events were low grade. So this was a very well tolerated agent. There was some longer term safety data looking at the long-term extension. So this is patients again on 400 milligrams of rilzabrutinib twice a day for 24 weeks using data from the LUNA-2 study. They looked at the patients who were eligible for long-term extension review, which is a platelet count of over 50 and doubling from baseline in more than 4 of the last 8 weeks. And 27 patients overall were eligible to continue on long-term extension. And again, they looked at the platelet response in long-term extension. The efficacy outcomes of the 17 patients receiving concomitant ITP therapy, 6 discontinued at least one of those concomitant therapies and 2 reduced concomitant therapies. And so for a median treatment duration of more than 2 years, the long-term extension patients showed higher and durable platelet counts with rilzabrutinib plus or minus their pre-existing ITP medication. So not only is it effective up front, but we seem to get good long-term extension responses and are able to reduce or discontinue concomitant therapy. And similarly, the safety data was similar to the data we talked about earlier. It's very well tolerated with minor adverse events. So moving on to an agent that we use a lot in adult ITP, but we thought it was helpful to show this data on pediatric patients receiving avatrombopag, because we have fewer options for these children so far, and it is important to be able to increase the repertoire of something that is an oral agent and well tolerated in the adult population, certainly. So this was a phase 3 randomized double-blind placebo-controlled trial to evaluate the efficacy and safety of avatrombopag for the treatment of children with chronic ITP, the AVAPED 301 study. And children with primary ITP for more than 6 months and a platelet count of less than 30 were included. They were stratified by age and enrolled into 3 cohorts depending on their age, kind of adolescent cohort, older children cohort, and a younger children cohort. And the patients within each cohort were then randomized 3-to-1 to receive avatrombopag or placebo. The primary endpoint was durable platelet count response in the absence of rescue therapy in more than 6 of the last 8 weeks in the core phase. And there was an alternative primary endpoint put forward of more than 2 platelet counts of over 50 in the absence of rescue therapy in the 12-week core phase. The baseline demographics weren't significantly different between avatrombopag and placebo group. And again, some of these children were quite refractory, with 68% of avatrombopag in the avatrombopag group receiving 3 or more previous treatments and 66% in the placebo group. The low numbers of discontinuation predominantly being around lack of efficacy. The time from diagnosis to treatment was more than 3 years for all patients, and most patients had at least more than 3 prior lines of treatment, with 71 to 74% receiving prior TPORAs. For the efficacy outcome, 27.8% of patients achieved a durable platelet response in the avatrombopag group versus 0% of patients in placebo. And the platelet response was 81.5% of patients with 0% in placebo. And the secondary endpoint shows significant benefit in the avatrombopag group for platelet counts of over 50, platelet counts of over 50 between 150 platelet count response at day 8 and rescue therapy treatment. So both the primary endpoint and then the secondary endpoints were in favour of avatrombopag, which was an effective oral thrombopoietin receptor agonist for children and adolescents with persistent or chronic ITP who hadn't responded to prior therapies, and will be an important addition for this patient group, particularly given that it is easy to take, an oral agent that's easy to take and manage. So moving on to a much newer agent in ITP, mezagitamab, or TAK-079 as it's known, which is an anti-CD38 antibody in chronic persistent primary ITP. And this is the interim results from a phase 2 randomized double-blind placebo-controlled study. Patients who were over the age of 18 with ITP for more than 3 months have been included, and they had to have a baseline platelet count of less than 30 on more than 2 or more measurements more than a week apart. They also had to have stable background ITP treatments. And the participants, of which there were 41, received subcutaneous TAC-079 or placebo for 8 doses, followed by 8 weeks of follow-up. Part A had 25 participants randomized 1:1:1 to receive the active agent 100 milligrams, 300 milligrams, or placebo. And Part B had 16 patients randomized 2:1 to receive mezagitamab 600 milligrams or placebo. The primary endpoint looked at adverse events of grade 3 or more, leading to treatment discontinuation, with some secondary endpoints of platelet response, complete platelet response, meaningful platelet response, and hemostatic platelet response. The baseline characteristics were, again, not significantly different between the TAC-079 and the placebo. And the primary safety outcomes, any treatment adverse event was no different between placebo and mezagitamab. The grade 3 events were slightly higher in placebo. Serious events fractionally higher in mezagitamab. Any bleeding much lower in mezagitamab, and any events leading to stopping the mezagitamab was 14.3%. So it has a very favorable safety and tolerability profile in adult patients with chronic and persistent ITP. But what did the response data show? So looking at the secondary efficacy outcomes, we can see that there is a benefit compared to placebo for all the response categories, both hemostatic and based on the platelet count. And that is the same for all doses that were tested, 100 milligrams, 300 milligrams, and 600 milligrams, but showing a trend to increase response with the higher dose, which was then selected for Part B. So I'm going to move over to my colleagues, because there's a lot of data to discuss here, and bring in the wider discussion on what you felt was most interesting and clinically relevant in these settings, Walid and Jim.
Yeah, I mean, all these new medications are very interesting. They look interesting. The results are good. What I found it intriguing is the savolitinib data with a durable response rate of close to 50%, which is something we're not seeing these days in this population. I mean, in the clinical trials. I mean, this study was performed in the Chinese population, and it is an ongoing that just has started in a phase 1/2 study in other parts of the world, and it will be followed by phase 3, and whether these data will be reproduced in the Western and the rest of the world, to say it that way, or the non-Chinese population, remains to be seen. And now this molecule is very different from fostamatinib. It's much more selective, and that is evident also by the different profile of the safety profile or the side effect profile. So it's quite interesting. It's a once daily also, not twice. Very interesting.
Walid, I love your analysis. I would just point out, relative to LUNA-2, that, as I think the members of the panel know at least, the spleen tyrosine kinase is upstream of the BTK. So theoretically, there should be some overlap between the two. I think in the previous agent, fostamatinib, which, as you said, Walid, possibly less specific, might not have been able to have its dose increased enough because of the non-specificity bringing side effects. That's a hypothesis, but the BTK inhibitor data from LUNA-2 is very impressive and looks good. I think avatrombopag being useful for children is great, as Vicky outlined, and they had an oral suspension for the younger kids. So assuming that that has good solubility, et cetera, that should work. And Walid, I'm curious what you think about the mezagitamab, because you've done a lot of the work with daratumumab, another anti-CD38 antibody for ITP. How did you think the results looked?
Well, these results looks very good. I mean, our study has been concluded, and hopefully we will present the results soon. The safety profile of this drug is also very good. So it's a kind of another promising agent that will be introduced in the future. How we are going to use all these drugs when they'll become available, it will be a challenge, but that also depends very much on the characteristics of these drugs, the remission rate, the toxicity, the mode of administration, all these things.
One last comment from me then. So we covered a whole wide variety of different new agents. We did not discuss anything about FcRn inhibitors, and we did not discuss anything about complement inhibitors. And at least in the US, there are now 6 different complement inhibitors licensed and approved for a variety of different diseases. And lastly, we didn't talk anything about combination therapy. So as you implied, lots more work to do in the future.
And bring those abstracts to the international meeting so that we get that data out there, because you're quite right, Jim. All of those things I think are important. So we will work away on that. Great. Thank you very much, Jim, Willie. That's been fantastic. And your insights on those abstracts across the board through all the elements, very gratefully received. It's been superb to have your expertise and work with you on this.